Good morning, everybody.
Morning.
Hi. We're gonna do a little concussion update today, and it's not a very long talk. Does anyone have any questions or cases before we start? Okay, well, we'll get going. There are a couple links on the website that go over the new, I'm not going to call them guidelines because they don't want them to be guidelines. It's just the new information, and then there's a new sideline and combination office form called the SCAT-5. So, I think one of the problems with concussion is we've had so many different forms and so many different formats and so many different things to do. And honestly, if you just want to use this one form now, I think it's perfectly adequate. So there's a couple links on our website, right? On our website, if you want to get those documents. And then I linked them in here too. They update we just did concussion in September. And I was going to actually have someone come talk on golf injuries, and then he called me and told me he actually has a golf tournament to play in. So I'm going to try to get him in August or September. But the new information on the sport-related concussion, it just came out in April. It's not earth-shattering, but I think it's a little bit simpler, and there are some changes. So if you're taking care of kids, or adults out there with concussion, I think that things are getting a little bit easier. We still don't have a lot of research and a lot of information, but I wanted to go through this with you. So basically, we're going to go through that new information. So like I said, about every 3 to 4 years, there's a big conference where they get everyone together and they talk about concussion. And then they come out with this consensus statement on, gee, what should we be doing? The interesting thing about this conference was they actually had some people there who were interested in the research on chronic traumatic encephalopathy and the long-term changes and problems that we think may be related to concussion. So they had those folks there. I think that was the first time. And what they're saying with this consensus statement is this isn't a hard and fast guideline. This isn't supposed to be a standard of care, a legal standard of care. It's just something to help you as you go through and take care of folks with concussion. So what they're really saying with this guideline is it's still up to you as a clinician to use your best medical judgment on how you want to treat these folks. So this time they decided there were going to be 11 R's. And, the first one, recognizing concussion, that's the hardest part. It's easy if the kid's coming off the field walking sideways and doesn't know who you are. No brainer, that one's out. But there are a lot of times when it's not really clear and you need a little bit more time. And what they're saying with this guideline is go ahead and try to take a little bit more time. Don't be rushed to put them back in. If you think, again, there's a possibility of a concussion, do some further evaluation, even if it means they might not play that day. And then they're talking about removing them, evaluating them. If you've decided they have a concussion, they need to go through the rest, rehabilitation. We'll talk a little bit about when to refer, how long it takes to recover, how to return to sport. And reconsider, they're talking about elite athletes and children. Again, we'll review that. Residual effects and the sequelae, and then what do we do for prevention and risk reduction? And like I said, unfortunately, there's no earth-shattering news here. We need more research. We don't have it. But we'll go through again. We've done sports-related concussion probably 3 or 4 times by now, I would say. So if you're tuning into these lectures, you know the definition, but I'll just review it so we're all on the same page. Usually a direct blow to the head, face, neck, elsewhere in the body, the impulsive force transmitted to the head, brain gets moved around, and the brain doesn't like that. You get this fairly rapid onset of what we call short-lived impairment of neurologic function. So really concussions are somewhere in the 4-week or less range for the most part. I do think it's important to note that when you think someone has a concussion, oftentimes that first 5 or 10 minutes, I wasn't sure. And they seemed pretty good, and they could talk to me, and they could say the things I wanted them to say. And oftentimes I'd wait, I thought I'm going to just give them 10 or 12 minutes, and I'd go back and re-talked to them, and then it became very clear to me that they did have a concussion. So those first couple minutes, you know, it just happened. They're walking off the field or the court or wherever you are. It's not always super clear that they have a concussion yet. Their brain hasn't come to the point where all the chemical neurotransmitters and the glucose theory and all that's happened. So give yourself a little time if you're not sure. It often becomes very clear in 10 to 20 minutes, and then all of a sudden they're, you know, off like this, and you think to yourself, boy, I'm glad I didn't put them right back in. So if you're suspicious, give yourself a little bit of time, because it can take a little bit longer than you think for some of that to show up. This is typically due to functional disturbance rather than structural injury. It's probably changing. We probably just don't have the tools to identify the structural injury at the micro level. But as we get some of the new MRIs and brain flow studies and things, it probably is indeed structural. It's just what we would call minor head trauma, because with the tools we use, like CAT scans and MRIs, you really don't tend to see anything. So probably in the future, we'll be better at saying, yeah, there is some type of structural injury here too. There's this wide range of clinical symptoms which can fool you, and again, you may or may not have loss of consciousness. Typically, though, the good news is these things resolve kind of in a sequential course, and we'll talk a little bit about the prolonged symptoms in some cases. So they started looking at things like, how do we diagnose concussion and how do we prevent it? One of the first things they came up with were that they looked at a lot of these biomechanical studies, because what people have been doing is putting helmets on folks who play sports that require helmets, and then they're trying to see what is it that causes the concussion? You know, is it a direct force head on? Is it the torque? Is it the twist? Is it an acceleration? Is it a G-force? What is it? And they're looking at the linear and the rotational acceleration, and what we really think is a lot of it is that rotational acceleration or that torque. So you can imagine I can hit somebody head on, and this is a pretty hard part of my brain, and brain might go back and forth, but as I fall down and boom, the side of my head hits somebody's knee, and then I get the twist in addition to the impact, you can imagine the brain does a little bit more. And so we're thinking there's probably a pretty big rotational component to this, which makes sense, and is why just putting a bigger, stronger helmet on doesn't really help. Because it doesn't help, you know, if you're twisting your head. I could have a helmet this big, but I can still get my head to rotate fast enough to cause a problem. And that also makes sense when we talk about prevention of concussion. There's some studies that neck strength helps. So you can imagine if I have a little tiny pin neck, that I can twist easier than one of the folks like this who, you know, the no neck. So that rotational component is important. And so some of the newer helmet systems that are coming out, and the NFL is testing one, has something for the rotational component. But what they're really saying with this is they're looking at these helmets, they're looking at the accelerations, they're looking at the video systems, and that everything is really variable and we can't really correlate. So if a parent comes in and says, should I buy my kid that $500 helmet? The coach of the team says, should we put sensors in everybody's helmet and pull everybody out that has a hit over a certain G-force? The answer is no, it doesn't correlate at this point, and the systems aren't supported. But lots of well-meaning parents will, you know, are buying this stuff, or schools are buying into it. You know, the Guardian caps, the things that you put on top of the helmet. Again, you can say no, the studies just don't support that stuff right now. And so let's get into concussion. Again, the majority of sports-related concussions, that's an SRC, occur without loss of consciousness, without frank neurological signs. And again, it can be difficult to diagnose. You're just not sure sometimes, especially in the littler kids, because they're just not quite as good at telling us exactly what happened, and then sometimes they're not as good at describing symptoms. We just don't have a diagnostic test yet. All the things that we're trying, the balance testing, the how fast you read, the blood markers, the spinal cord, the brain fluid markers, just don't have anything yet. So again, what needs to happen is if you or somebody that's working with you or for you, or this is a coach or a parent on the sideline, thinks, hey, maybe little Johnny or Sally had a concussion, they need to come out of the game and have an evaluation by some sort of a licensed healthcare provider. And it just, depending on where you are, this could be an athletic trainer, this could be EMS, a nurse, a school nurse, a physician, a PA, a nurse practitioner, somebody that, you know, may be around, but somebody who knows a little bit about concussion should probably assess these folks. And I talked a little bit before about the SCAT-5. This is the new document. So it's a Sideline Concussion Assessment Testing document. It's got one section that is sort of for the immediate on-field assessment. And it goes through the real red flags and the emergency stuff where we're not thinking concussion, we're thinking a more serious injury. They go to the hospital. And then it evaluates, okay, this might be a concussion. What should I do now? I'm going to give a little time and I'm going to do a further office-based or, you know, in the locker room type of an assessment. So this is a good form to use. The first time you use it, keep in mind, you know, they say, gee, it should be able to be done in 10 minutes or less. The fellows, when I would give them this and have them start out in August and September, easily took them a half an hour. And, you know, they might get to where they could do it in 15 or 20 minutes. So it's not a super fast, once you get to the office assessment, it's not super fast. It takes a little time and you just need to realize that. And the fellows, keep in mind, they were doing 100 or more concussions in a year. When you're in an office-based practice, what are you doing, 5 or 10 maybe? Depends on your practice, but just keep in mind it takes a little bit of time and it's helpful if you have somebody who can help you do it. But what it says in terms of the emergent or first part is you need to look and make sure that there's not something so serious that that's more of a major head trauma, neck trauma, something else, off they go to the hospital. So they've got the red flagged part. Then we're going to talk about observable signs. What kind of things do you see that might make you think this person has a concussion? Then you want to do a little bit of memory assessment. They put the Glasgow Coma score in there. Obviously, most people with concussion, which we call a minor head injury, are going to get a good Glasgow score. If you have something lower, puts them in a different category, off to the hospital. And then they really want to emphasize that the head and the neck are connected to the body, and you want to make sure that you assess the cervical spine. So on field, first thing, someone gets hit, goes down, not moving, looks funny, you want to get out there and check them, and you just want to make sure, are we dealing with a more serious type injury? So do they have neck pain or tenderness, double vision, weakness or tingling, burning in the arms or the legs? That can be a stinger if it's on one side. If it's on both sides, it can be a possible cervical spine injury, some kind of a cervical stenosis, something that is congenital, et cetera, et cetera. Severe or increasing headache, seizures or convulsions. Again, you can have those fairly commonly with concussions and they're scary. They don't always mean there's something bad, but it's enough that it makes me send them off for an evaluation. Loss of consciousness, again, especially if that's prolonged. Deteriorating conscious state, sometimes you can watch them sit there and they get worse and worse. And the few subdural hematomas that we've had, that's exactly what happened. I actually sent them down to the ER with an athletic trainer. Athletic trainer called me after about a half an hour and said, gee, I hope the ER doc comes soon because now he's not making sense and he's mumbling and he's slurring his words. I said, I'll call right now. We'll get that one looked at. So again, as you're watching them, things can deteriorate over time. Vomiting more than once, and then again, kind of personality changes. They get restless, agitated, combative, stuff like that. We need to look at them. So you get out there, maybe they're lying motionless. Oftentimes they have balance and gait difficulties. They're uncoordinated. They may be slow, especially if it's, I kid you now, kind of looking at you like, who are you? That blank or vacant look is really common. They don't respond appropriately, don't know what they were doing, what was happening, what was their particular part to play, you know, maybe in the play or, you know, what was happening in the game. And again, the ones, I've missed a couple concussions along the way, and I've missed them because I was focused on the facial trauma, facial injury. Gee, I can suture that up and get them back in the game. I'm so proud of myself. And then I watch them out there going, and I think I totally missed the concussion because I got focused on something else. So make sure, even if there is a neck facial trauma, something like that, do the concussion evaluation too, because it usually means they got hit hard enough that that would be a possibility. So as far as the stuff you can do quickly on the sideline if you're seeing them, or gee, they brought them right into the hospital or the urgent care, make it appropriate or pertinent to what they've been doing. So, you know, where are we? Gee, we're in Yarrington. You know, what half is it? Or what part of the game are you in? Who scored last? Or what's the score? What team did you play last week or the last game? And for the rodeo cowboys, it's oftentimes, where were you last week, or what bull did you ride last week? So maybe you, again, down at the bottom, you can substitute sports-specific questions. They were motocross. You know, well, did you race last week? Where? So you can make those a little specific. You know, did your team win? What happened? Again, the Glasgow coma, I just threw it in there for you, but typically most people should be in the 14, 15 range. Anything, you know, that's lower than that, even a 14, I would be worried a little bit about what do I need to do, and should that person be assessed. But they want you to do a Glasgow coma scale on them. So it's pretty easy if they're fine, you know, they open their eyes, look at you, and speak to you normally, shake your hand, everything moves okay, you're done, that's good. But anything less than that should be sent for further evaluation. And again, does your neck hurt? No. Okay, feel it, push on it. Does it hurt? No. Okay, now go ahead and let them move. Does your neck hurt? No. Yes? Okay, stop. Let's get the backboard. Let's get the collar, et cetera, whatever your local policies are, and get them someplace else. And then again, gee, their neck doesn't hurt. Gee, it moves okay. Quickly check their arms and legs. Everything moves normally. Sensation's okay. You can grab and you can wiggle your toes and push against me, you're done. That can be a really quick assessment on the field. This, there's always second guessing, especially on TV now. You know, you'll see people come off and you're like, wow, that guy or that gal had a concussion. And then they go back in the game later. And I'm often like, oh, that was a dumb move. They shouldn't have done that. But I've been in the position too where they've come off the field looking really wobbly and not walking well, and for all the world, I think they have a concussion. And I know I told you this story. I had a kid come off just like that, and I grabbed his arm and I'm like, you okay? How's your head? And he goes, it's not my head, doc, it's my down below region. I'm like, oh, okay. So we go into the locker room, and then, you know, he'd had some trauma there and got pinched, and it hurt a lot. And he was wobbly when he walked off, and we got him all fixed up with a few different maneuvers and put him back out there. And I actually had people text me and say, how stupid are you to put a kid with a concussion back out there? And he hadn't even hit his head. But you can't, you know, we don't talk to the media, and we certainly don't tweet back, you know, with confidential patient information. It's not always what it seems. So if actually a healthcare provider does a full assessment, they, you know, and it's not really a concussion, they can go back in and play if you haven't diagnosed it. Again, especially with the littler kids, gee, you know, it's a Pop Warner football game. Just err on the side of the caution and say they're out. There is sideline video review. Again, if you're in a rural area, you may not have this, or you might. There might just be someone in the stands that's doing it. Certainly at the higher, at most of the college levels and at the professional levels, they have this. And so what they're trying to do is, gee, did he really get hit that hard, or what happened? And sometimes you can actually go back and look at the play, and it may give you some additional information. They're actually using it again in some of the professional sports. There's a designated watcher who may say, hey, Sally Smith got hit really hard on that play. You might want to grab her and just take a look at her. You know, a radio down to the sideline, and you can go grab her and do a quick assessment. So it may be helpful. Again, you still need to watch them a little bit because of that delayed onset of symptoms. These are the things that we think about: headache, foggy, emotionally labile, the loss of consciousness, amnesia, neurologic deficit. Those may be a little more serious. Balance impairment, oftentimes after concussion they have an unsteady gait. Kids will be irritable or crying, kind of inappropriately. Cognitive impairment, slowed reaction time, sleep-wake disturbance. Some of these you can tell occur sooner, some of them occur later. The problem is if you look at any one of those, almost any day, any teenager could have one of those, right? So sometimes it's nonspecific and not diagnostic of concussion. And I had a kid who was going to be held out of she was a college player, not my patient, went to school somewhere else, was going to be held out of the finals of a really important basketball tournament because she developed a headache after the game and they thought it was concussion. Well, I helped him out a little bit and went back and talked to the physician, and it turns out she and the athletic trainer, she had migraines, and she'd simply gotten a migraine after the game, and it wasn't, they looked through the film and she never did hit her head at all. So again, these aren't specific and diagnostic of concussion. They should make you suspicious, but keep in mind people have other things that happen. Again, if you think someone has a concussion, though, they need an emergency evaluation, a first aid evaluation. Is there a more serious head injury, neck injury, chest injury, lung, et cetera, et cetera? Then you need to decide what's the disposition. Can they sit on the sideline because it's a concussion and they're okay to be there? Should mom and dad take them home? Should they go by EMS transport? So first thing you want to do is check them out, and then you got to make your decision of they're okay, it's not a concussion, you're going back in. I want to watch you a little bit longer. Hey, it's more serious. I need you to go off to the hospital. And that's where you can use this SCAT-5. You can do the emergency on the sideline stuff, and then you can go to the further evaluation. Because these things can evolve, and even more serious head injuries will evolve, you really don't want to say, hey, just go off to your dorm and sleep it off for the next 6 hours with nobody around. You really want to have somebody evaluating them. If you're on a road trip someplace and you're going to drive on a bus 4 hours back, is there someone that's appropriate to evaluate them? And gee, can you stop somewhere on the way if you need medical care? If you're going to, we had this issue in Hawaii. If I'm going to put them on an airplane, I can't pull over in the middle of the Pacific Ocean. So I had to decide, are they safe enough to go on an airplane and can, have 4 or 5 hours where we can't get to healthcare, or should we leave them in Hawaii, or should you leave them where you are? So that happens every once in a while if you're with someone who's traveling. And again, if you think they have a concussion, or if you diagnose a concussion, no matter who they are, no matter what level athlete, they should not go back in and take a chance of hitting their head again that day. So once you get through the sideline stuff, what's next? Again, use that sideline screening for a rapid assessment as kind of a triage guideline. Where do they fall? And then you can do some additional evaluation. And again, their test says it takes 10 minutes, but plan for 20 to 30, especially if you're not really familiar with it or you haven't used it a lot. And again, you don't want to try to do this on the sideline. You see this all the time on pro sports. We're taking them back to the locker room for the concussion assessment. And they have some more sophisticated testing modalities that they use. But no study says it's any better than this SCAT-5. And so it's perfectly viable and valuable for you. If you want to use a good concussion tool, this is the one to use. You just want to take them off somewhere and do it in a distraction-free environment and have them resting. So neuropsychological, the computerized testing, the impact test, the headminder, those tests got really popular for sure in the last 10 years. Unfortunately, what happened is they say, well, we have the impact test. It's basically a smaller computerized neuropsychological test. So it doesn't take the place of a neuropsychologist doing full testing. It's a screening test, but what happens, a lot of places are like, well, we think they've had a concussion, we'll do the impact test. The impact test says, yeah, they've had a concussion. Well, we'll do it again in 4 to 5 days, do it again in 4 to 5 days. Someone reads the test, says, that's done, and then they get cleared to play. And you gotta keep in mind, this is a tool. A healthcare provider needs their eyes and hands on these people. And you know, it's a helpful tool, but I think it's starting to be used as, well, this is the end all, and school districts and things, we're going to do this test and we don't ever need them to see a healthcare provider. I'd rather not do the neuropsychological computer test and have them see a healthcare provider. So they're actually agreeing on this one. They're saying, hey, it's great if you have this. You can do baseline testing. You can do post-injury testing. It's another tool. I liked it for me, especially at the college level. I got to say, hey, neuropsychologist, take a look at my patient as well. You know, it's kind of like pulling someone in when you have a rash. Hey, Cayman, come look at this rash for me. What do you think? And you always feel a little better when you have a colleague saying, yeah, I agree with you, or, hey, no, I know what it is, it's this, or, you know, no, I don't agree with you, we should do something different. It's nice to have that second set of eyeballs on them, but it shouldn't be the sole basis for management, and it has evolved into that in some places. So that's just use it as a tool. If you don't have it, that's fine. You might just be a little more conservative in your return to play guidelines, depending. So that's all they're saying now, is they're saying, hey, it's a tool to help you. It shouldn't be the sole basis for all your decisions. And somewhere along the way, everybody, all these athletes should have a neurologic exam. So we're talking about the stuff that's in the Cat 5. And again, that baseline testing isn't mandatory, but what they're saying it's really good for is these kids have to take this, and are in Washoe County school districts, is the impact test. Well, that means you have to send something home to the parents saying, hey, can they take this test? Maybe it costs $5 to take it, but it provides an additional opportunity for you to do some concussion education, which is a good thing. So it's almost that talking about the test and saying we're doing it and we're addressing concussion is important as doing the test itself. But if you're in a school district or a place that doesn't have it, you've got the SCAT 5 and it's okay. You don't have to have it. On the other hand, if you want to implement that kind of a plan, there are neuropsychologists in Nevada that will help you. It's web-based. You don't have to have one in your town. So you can, there's a cost to it, of course. You decide which one you're going to use. You can sign your school district or your team or your ski team or your rodeo team or whatever. You can sign them up, pay the cost. It's not super expensive. And then you can work with a neuropsychologist in a remote place to do the computerized testing. If something looks bad or it becomes more serious, that neuropsychologist is probably going to say, hey, Dr. Smith, this young person or person needs to go in and have a more formal assessment with a neuropsychologist, which is an in-person assessment. There's lots of new things that are using for investigation. And again, we talked about the functional MRI, some of the cerebral blood flow, the other types of MR studies, some of the heart rate things, measure of performance. They're looking at heart rate, it goes up faster afterward, the fluid biomarkers where they're talking about should we be testing blood, saliva, cerebral spinal fluid. Genetic testing, looks like there's probably some type of predisposition to some of these things. Transcranial magnetic stimulation, are these things helpful to us? No. They're in the research realm. They're not validated for clinical use yet. They're currently helpful as research tools. There's even a Sideline EEG device that you can put on and do a quick check and say, hey, brainwaves look okay or not. So there's probably going to be some of this stuff in the future. We may treat it like we do, rule out MI protocol. Well, let's check the biomarkers and let's check them again in 4 hours and gee, you had a concussion or you didn't. But we don't have any of it yet. This is one of the changes. We're moving away from lock you in the dark closet for a week and complete rest. It looks like it's probably not really helpful for a few different reasons. And think about a lot of the kids that we're taking care of are in junior high and high school. And if you take them away from their sport and their friends for the whole week, they start having some psychological issues too. So moving away from complete rest and saying, okay, some brief rest for 24 to 48 hours. You had a bad concussion, you really don't feel that good. So do a little brief rest and then you can become gradually and progressively more active. This is not go run 10 miles day 2 of your concussion, but this is Well, get out and go for a walk. Maybe we can get you on the exercise bike a little bit. And it looks like it probably is helpful. And actually, some studies are looking at using this as treatment. Can we get them back faster? Do they heal faster if we start doing some progressive exercise? So again, we're not ready to recommend that. We want them to stay below the threshold that incites their symptoms. So if they go out for a walk and they get a bad headache, they need to come back and not, wait till tomorrow and try to go for the walk. Same thing, you put them on a bike or a treadmill and they get symptoms, just take them off. So you don't want to do super vigorous exertion, but really getting them doing something fairly quickly is in the realm of the future. So who should you refer? 2 weeks for adults, it's continuing. That you might want to have them see somebody who specializes in concussion, and this might be physical medicine and rehab, this might be the neuropsychologist, depending on what you're dealing with. This might be a neurologist, but a sports medicine person who specializes in concussion, somebody else, if it's 10 to 14 days for adults, but 4 weeks for children. So just keep in mind, we start getting nervous, gee, they're not better at a week. They're not better at 2 weeks. Oh my gosh, it's 3 weeks. Something really bad is wrong. They take 4 weeks. And that's in the realm of normal. So certainly if you're clinical judgment and you're uncomfortable, get them to somebody. But if you're comfortable and you can help the parents and the child understand this is going to take this long, then a lot of times everybody settles down. Right off the bat, this might be a month. Rather than, oh yeah, we'll have them back in 3 or 4 days. So you can set the parameters and you can discuss these things right off the bat to sort of, here are the expectations, and it might be that it's 4 weeks, it might be 6 weeks with the younger kids. There are lots of these confounding factors, and we talked about migraines before. It gets confusing. If you have a player coming into a contact sport who has migraines, when we saw the soccer players and football players with migraines, I was like, oh boy, it's going to be hard to tell because there are exercise-induced migraines, heat-induced migraine, those kind of things happen. Depression, there are changes with concussions, but depression, they tend to not get better quite as fast. ADHD, folks who already have some type of mental health issue, and certainly we don't always think about it, but substance abuse. Now we're not letting them have their substance and they're withdrawing, or, gee, they're using their substance on top of this brain injury. It gets really confusing. Like, what is going on? And sometimes you need to talk to them about, are you drinking? What are you using? Or like I said, are they withdrawing because we've told them not to, or we're not giving it to them and they can't get it? So keep in mind the substance abuse part complicates this stuff. There's really limited evidence for pharmacotherapy as far as treatment. It seems perfectly reasonable to say you can use some Tylenol, you can use some Advil. Sometimes for the post-concussion stuff that goes a couple weeks, I'll use some Elavil. There's just no good studies that say this helps. I had a neurologist who oftentimes would use triptans for the headaches. And again, in my experience, that seemed to be helpful. You have somebody with terrible headaches, especially if they have a migraine history, but limited evidence. What this I want to call a guideline. They don't want to call it a guideline, but this clinical consensus document says there are just no studies that say, here, use this medicine, here, use the fish oil, here, use the turmeric, or whatever is the latest popular supplement out there. None of those studies are out that says this is helpful. Again, if you're not sure, refer to someone, healthcare professional who works with concussions. Recovery, most people get better. Without a lot of intervention, it's still time. And G, keep your head away from getting hit again while you're recovering. We think that's a big deal. Really severe initial symptoms do predict a slower recovery. And again, like I said, pre-injury migraines and mental health problems are risk for having symptoms greater than a month. So you might set up that expectation right in the very beginning. Teenage years, there's a lot going on. And what they're saying is it might be a more vulnerable time period for your brain. And then you have these kind of more complicated things that can happen. Greater risk for girls than boys. Draw your own conclusion about why that might be. But that's what seems to be out there in the literature. And there's this physiological dysfunction that may last longer than the clinical symptoms. So again, in the future, we may be doing some functional MRIs and EEGs after the clinical symptoms are gone. Some of these folks still have some of these physiological symptoms. The cerebral blood flow seems to maybe linger after the clinical symptoms are done. So this buffer zone they're talking about is, okay, my symptoms of a concussion are done now, today. But nobody puts me right back in with the football helmet and full pads in practice today. We have this return to play protocol, which really gives us about another week before you're putting me back out there and allowing me to hit my head. So that buffer zone may allow the physiological recovery too. Again, there's a lot we don't know about concussion. But the return to sport should be stepwise, and when they're symptom-free, they can begin the symptom-limited activity after 24 to 48 hours, but this is not the return to play protocol stuff, okay? So just because at 48 hours I can ride the bike and not get symptoms, that doesn't put me in day 2 of the rehab. I need to be totally symptom-free, and then you begin the return to play protocol. So you're thinking about 7 to 10 days to get better from your concussion, and now another 7 days to get back to the return to play. So you've got, you know, junior high or younger kids, you're talking about a month, but high school, you're still talking about 2 weeks. So set that expectation for the coaches and the parents. It's not probably going to be a week. And the state championship is in a week, probably not going to have them back by then. And then everybody knows, and they can get mad at you and go somewhere else, but anyone who specializes in concussion will probably back you up. and so then you start your rehab protocol. Each step should take about 24 hours. So typically, gee, you made it through this step, great. Tomorrow we'll go to the next one, we'll go to the next one. You get to step 3, gee, I got a headache and I got dizzy. Okay, we're gonna stop for today. We'll go tomorrow, but we'll start, you know, at the lower protocol and just work you back up. So again, if they get symptoms, you just stop that day and start at the previous asymptomatic level. And then just go back up from there, bothers them again, back they go. This I just put in so that you can see it and what it entails. We don't have to go through all of it, but you can see how it's gradually progressive, and the full contact practice is there at the end, and then the return to normal sport play. This is important too, because they're going to school, right? Especially if you're taking care of folks who are at the, you know, the professionals, maybe not, but certainly the college kids I take care of, and if it's high school or junior high or earlier, they're going to school too. They may have symptoms and have problems. So, you know, again, don't confiscate their cell phone and not let them look at a computer. They live with this. They're going to get depressed and have some problems with that, but hey, we might limit the time, screen time, TV time, computer time, studying time, depends on how they do. But again, here's a guideline for returning to school. I do think it's important to note that they should be back to school before they go back to their sport. So I'm not going to hold them out from class, but you can go practice. So you got to be back in school and doing your school stuff, and then we'll get back to your sports. This reconsider is that, gee, should we treat elite athletes differently? Should we try to get them back faster? And they're saying no. They really should follow the same exact guidelines as everybody else. And trying to get them back faster or ignoring symptoms or getting them in there with symptoms is going to be detrimental to them in the long run. We really don't know much about the littler kids, the 5 to 12-year age group. These kids, the way they oftentimes get concussions, I'm usually not playing football hard enough to get a concussion. What's happening with them is they fall off their bike, they motocross, their skateboard, the monkey bars, something like that, and they hit their head. So you'll see these, and again, just take plenty of time with them. Adolescents, again, we don't have a lot of studies in those age groups, and we need some more studies. But expected duration, and you can set the parameters for the parents and the child. This will probably be 4 weeks that you're going to be out of your whatever sport it is. Schools really should have some type of a sport-related concussion policy, so when you call or write a note, they know, okay, this kid gets some limited activities, and certainly there has to be some communication to the athletic director or the coach. This kid is not supposed to be at practice and playing. And again, you know, the parents might be in there too, but I've had some good experience with parents and some that aren't so good about getting their kids back too soon. And so again, your part is education, but really you should have some type of communication with the school or that team directly so that they know what your ideas and guidelines are. And again, they said right there, probably shouldn't be going back to sport before they're going back to school. Okay, this is a big deal. Everybody's heard about this, right? Chronic traumatic encephalopathy. And for sure the pro football players who die oftentimes, you know, they've died young or something bad or worrisome has happened, suicide, etc., and they're donating their brains. The problem is the sample and the sample size. So all we have are a small number of these guys, mostly, who had problems. You know, we don't have the brain of everybody who's played in the NFL for the last 40 years. And that's really what you need to do to know what the incidence is and is it related. And so we have to be cautious, and it probably is not a great idea to get your head hit 40 times and have 40 concussions, but it doesn't automatically mean if you have 1 or 2 concussions, you're going to get chronic traumatic encephalopathy. So more studies need to be done. The potential is there. You have a kid who's had 5 bad concussions and they want to go back and rodeo, motocross, football. I would strongly say let's talk to them about not having any more. Maybe you need a different sport. But the true incidence of this stuff is unknown, and whether it's even really related to the head trauma is unknown. So although you read, you know, the media, you read, hey, you get a concussion, this is what's going to happen to you. And there's people that are really passionate about this on both sides, but the truth is that the studies aren't there. The cause and effect relationship between sports-related concussion and chronic traumatic encephalopathy is not there. There's not a cause and effect relationship. And you need to keep in mind with a lot of the people who've played pro sports, whether you want to hear it or not, alcohol, drugs, performance-enhancing substances are huge. And it's hard to tease that out from everything else. So some of the lifestyle things are there. So all I can tell you right now is we don't have a direct link. Keep it in mind. And I do think it's bad to have your head hit a lot. But if I've had a couple of concussions myself, do I anticipate that I'm going to get chronic traumatic encephalopathy? No. The relationship between this repeated concussion over and over and over, again, that's also less clear, but probably a little more worrisome if you have a lot of bad concussions. And these subconcussive impacts, so what they're talking about is these kids who get hit a lot, and they're looking at a lot of the football linemen who maybe get hit 30 or 40 times, hit their head 30 or 40 times in a game, never enough really to have a true concussion. We don't know if that leads to some of this. It might not. Again, studies aren't there, so take that with a grain of salt. It's not for sure that you played professional football, you're going to get this. How about risk reduction? What happens when someone comes in for their pre-participation physical and they've had 6 concussions already, and you're going to clear them for girls soccer, which is a high-risk concussion sport? That's where you need to have a talk, because we do think a past history of concussion probably gives you a little more likelihood to have a future concussion. And it may put some of these in a high-risk category, and it may be someone that's so high risk you say, we should either change your sport or we're not going to allow you to keep playing. And that happens. You know, I've disqualified a number of students from sports, and sometimes they've gone to another school and gotten cleared to play. And, you know, again, this is a clinical judgment. It's great to sit down with a student, and depending on how old they are, with their parents, even if they're old, maybe with their parents, and talk about, hey, you've had 5 or 6. Is it worth it to keep having more? And we don't know exactly what might happen to you as far as chronic problems, but I do think it's not great to have those kind of head injuries over and over and over. Previous symptoms. Did it take them 6 months to get over a concussion? How long? How bad were their symptoms, and how many? Those are important. Have you had a previous spine, cervical, facial injury, a bad one? Maybe that they also had a concussion with that. They've already had 5 or 6 concussions and had 2 bad facial injuries. You know, they're getting in that realm of how many is too many. This disproportionate impact versus symptom severity. So, gee, I had my first concussion and it took a truck to run over me, and the next time a fly swatted me on the side of the helmet and had a concussion. You know, they start getting concussions with less and less trauma. You need to think that person's really susceptible. Their brain might not like this. Maybe we ought to consider not playing this sport or not doing this or doing something else. And again, you want to educate the athlete and discuss modification of playing behavior or sport. You know, there are some kids who, and hopefully the coaches are teaching them, but, you know, they're teaching them to get their head out of the way, not fly in there with your head down, which really can cause a neck injury. And, you know, just those kids who are really gunners as far as hitting heads, and maybe you can discuss modifying what they're doing. Prevention. The evidence is limited in sports that always use helmets because we aren't going to take the helmets off and do the study, right? You have to play football without a helmet. Let's see if you get more concussions or not. So the problem is we just don't have those studies to be able to do. There is the skiing, snowboarding, the helmets really do reduce risk of head injuries. So if you have a kid or you're counseling children or parents or young adults on skiing and snowboarding, they should be wearing helmets for that sport. And that's not mandatory because, you know, you just go pay your lift ticket and up you go. But if you're the physician or healthcare provider counseling them, they should be wearing the helmet for those 2 sports. The mouth guard, there might be a little trend toward a protective effect in collision sports. Certainly it helps with dental injuries. So yes, they should be wearing their mouth guard. Don't tell them it's going to prevent a concussion, but it certainly prevents them having their teeth broken and knocked out. So their mouth guard should be in. There's a study that no body checking in youth hockey until they're greater than 13 does help. So that was a rule change that was helpful. There's a small study doing this vision training. And that probably has to do with being able to see someone coming at you and get yourself out of the way so you don't have the impact. They have done a lot with limited contact in youth football, and there's less head contact, which is probably good, but it's really unclear if it actually reduces concussions. Again, just studies aren't out there, and you can imagine how hard that is to do in Pop Warner football. And having concussions aren't that common anyway, so just having the documentation and the research isn't there. They have looked at different things as far as fair play rules in hockey, where they change the rules a little bit. Tackle training without helmets and pads in football, which kind of makes sense. And rugby football tackling technique, there's no study that says that actually helps prevent concussions. Although we might think it does, and I think it's good not to hit your head when you don't have to. There's just not a research study that says this is helpful. It still might be helpful. We just can't say it is. They talk about the knowledge. And so just talking to your students and your parents about concussions, coaches, administrators, I think the biggest thing is just to be able to recognize it and get that person out of the game and evaluated. That's probably, you know, one of the key things that's important for concussion, and that really means having someone around the sideline that knows what to look for. And you know, especially if you're in a rural area, that may be few and far between. If you're at the college level, you have 6 athletic trainers and usually 4 or 5 physicians hanging around. And if you're a junior high in Winnemucca, I don't know, you know, who they might have there that day. But it is important to get the word out, and education may lead to the improved identification. We think if we can identify people, pull them out, not return them until they're feeling better, and maybe not let them get 10 concussions, that probably is good for their brain long term. And then just the fair play and sport ethics of not trying to hurt people and following the rules, because a lot of the rules are meant to try to help decrease concussions. So in conclusion, the science is incomplete. I think you can see they've pulled back a little bit on some of this stuff, you know, the strict rest, that everybody has to have computerized testing, these different pharmacos, you know, that stuff, there's just not evidence for it out there. So it's still recognize it, pull them out, give them time before they return to school in their sport. And if you're not sure, get them to somebody who specializes in concussion. But in the end, the computerized testing, all the other fancy things, it's really up to you as a clinician to say, I think this is a concussion and I'm going to do the appropriate thing here. So it's really left up to you on an individual basis. Here's the statement if you want to read it. And I think that SCAT-5, you know, there have been a lot of different forms out there in the past. That's probably a good form to use. You've got it for the sideline, and if you want to use it in your office, some of the things could be done by your MA or your nurse or your front desk. Again, like I said, there's a little part for the sideline for the emergency stuff, and then there's a little bit more formal evaluation that you can do in the office, and you can use it for a follow-up as well. So see, all that stuff's the immediate or on-field assessment. And we went through that. Can you keep going? Is there more? Yeah, there you go. So now we get, you know, now you get to the office. Somebody else can help you fill out a lot of this, and the symptom evaluation, the student or the patient actually does themselves. And then keep going down, you'll see. This stuff takes a little while. That's why I'm saying, even I who do it a lot, I tell my my nurse or my medical assistant, I'll be in there for 20 minutes. You know, don't worry if you don't see me. So you go through all this, keep going down. And then there's even a little section for concussion injury advice that you can cut off and give to the parents or whoever's watching them. And the instruction tells you just how to do some of this stuff. So again, I think it's a pretty good form to use now. They've put everything all in one place, and that's really what we like and want. So if you want something to do official concussion assessment, that's the one to use, I think, at this point. Does anybody have any questions about that? It's a little simpler, so, you know, it's not quite as overwhelming, and I think it's nice to know you don't actually have to have the computerized testing if you don't have it already, but if you want to have it, let me know and I can always help you with that. And if you have questions about these kids or want to know who to send them to, again, just get in touch with me. Thank you.